Everyone, I am Divya, and today I'll be presenting on nasal septal perforations, a case presentation and an approach to such pathology. Starting off with my case presentation, a 57-year-old gentleman presented to ENT OPD with chief complaints of 3 episodes of epistaxis, each lasting for an hour and lasting for 3 days. The bleeding stops by pinching nose, and he reports it was more of an anterior bleed than a posterior bleed, scanty in amount and not associated with clots. There is no history of trauma or finger pricking. He is a known type 2 diabetic with hypertension, well controlled, and he reports of sinus surgery done more than 30 years ago. He is not a drug abuser and unexposed. On examination, rigid nasal endoscopy revealed a 2 by 1 centimeter anterior septal perforation with bleeding points over the anterior and posterior margins of the perforation. The superior and inferior margins were normal. Rest of examination, which included throat, neck, ears, oral cavity, and nasopharynx, was normal. Hence, a diagnosis of epistaxis secondary to septal perforation was made, and the patient is due for follow-up in 6 weeks at our ENT OPD in order for us to assess the septal perforation, whether the margins have healed. If we still suspect that the margins are looking suspicious, we will go ahead to do a biopsy. So let us have a look at how we must approach nasal septal perforation. Starting with the definition, a nasal septal perforation is defined as a communication between 2 nasal cavities that is caused by a defect in the septum, either as a result of necrosis of mucopericondium or mucoperiosteum, followed by necrosis of the cartilage and or the bone. It in fact is seen in 0.9% of the general population. Nasal septal perforations can be classified based on their diameter. A small nasal perforation has a diameter of 0.5 centimeter. A medium septal perforation ranges from 0.5 to 2 centimeters, and a large septal perforation is more than 2 centimeters. Of note, a complex perforation is defined as one that is seen in a patient who has had previous failed closure of the septal perforation, or a patient with granulomatous and autoimmune disease, or a patient who's been exposed to radiation. Now, when we have a look at etiology, we can broadly classify the causes of nasal septal perforations into 5 categories. Number 1, and being most common, is traumatic causes. And amongst the traumatic causes, the most common cause is nasal surgery. But we must not forget that even a septal cauterization done bilaterally can lead to eventual septal perforation, and it has also been seen with traumatic NGT insertion. Among surface irritants, it's important in our history to find if the patient is a cocaine or heroin abuser, and if the patient has long-standing nasal spray decongestant use or intranasal corticosteroid sprays use. Amongst infection, we note syphilis, TB, rhinoscleroma, rhinosporidiosis. And amongst neoplastic causes, we've got squamous cell carcinoma, adenocarcinoma, melanoma, and lymphoma. Amongst inflammatory causes, there's Crohn's disease, sarcoidosis, and granulomatosis with polyangiitis, which was previously known as wedge nose granulomatosis, that we must always keep in mind. So as I mentioned earlier, nasal surgery accounts for is the most common cause of nasal septal perforation. Hence, in surgery, if we find that we've got a laceration through and through to the opposing mucosal layer, we must immediately suture it and prevent further damage. There are 4 pathogenic stages that account for the symptoms patients with nasal septal perforation. There is a first stage where there's a local inflammatory reaction, whereby there's erythema, swelling, and crusting. A second stage where there's decreased vascularization, leading to cartilage ischemia. A third stage where there is cartilage ulceration and necrosis, and a 4th stage where the borders of the perforation are covered with atrophic epithelium, leading to possibility of bleeding and crust formation. It's interesting to note that an anterior perforation is more common and accounts for 92% of cases and are more symptomatic compared to the posterior and superior perforations. And the reason is because posteriorly in the nasal cavity, there is a high intranasal humidification. And posterior and superior perforations are more commonly linked to systemic diseases. Now, why do symptoms occur is because with the perforation, there's a loss of intranasal airflow, and this results in turbulent airflow, leading to subsequent damage to the epithelium and impaired nasal function. Hence, patients will present with epistaxis, crusting, nasal obstruction, facial pain, nasal discharge, frontal headache. Small perforations can lead to a whistling sound, and large perforations can lead to atrophic rhinitis. Sometimes we can even observe cosmetic deformity, such as saddle nose and columnar deformity. Now, in our history taking, how do we evaluate such patients? Firstly, we must see, is the patient symptomatic or not, as this will further help us in treatment plans. Surgical history, to know if the patient has had a previous nose surgery, and if so, was there previous attempt to repair the septal perforation? In medical history, we want to know comorbidities, as we want to know is the patient fit for general anesthesia, and if there is any traumatic, infectious, inflammatory, or neoplastic etiology we could think of. We must also find the drug history, whether he is a cocaine abuser, a smoker, and if there's misuse of topical nasal medication. And in medical history, we want to see is the patient on anticoagulation. Coming to physical examination, when we do a rigid nasal endoscopy, there are 5 main criteria we want to have a look at. Firstly, what is the location of the perforation? Is it anterior, posterior, inferior, superior, and other one or multiple perforations? Secondly, the shape of perforation. Is it circular or elliptical? And in shape of perforation, we want to specifically look at the vertical height of this perforation, as it's been seen in studies that the height of less than 1.2 centimeter has better success rate than those more than 1.2 centimeter in vertical dimension. We want to see the size of the perforation, if it is small, medium, large, as this will, as I'll come later on, help us in deciding which treatment plan. We want to assess the underlying cartilage, palpate the septum by use of a cotton tip applicator, and we want to assess the mucosa surrounding the perforation. If there's any abnormality, we can go on to biopsy. The special investigations include full blood count, urine electrolytes, urine analysis, C and K, P and K, troponomal antibodies, TB testing, chest X-ray, and biopsy. This is a nice table taken from a paper by Andrew C. Swift, which tailor-made the investigations to the clinical features. If we have an anterior perforation, healthy margins, and a clear history of trauma and surgery, there is no further investigation required. If there's an anterior perforation with crusting and inflamed edges, then we must proceed to do a vasculitic screen, culture swab, and if the markers are positive, proceed for a biopsy, and then consider CT scan. If there is an anterior and posterior perforation with associated granulations and crust, we must think of TB and syphilis, and also of Wegener's granulomatosis and sarcoidosis. And of course, if we suspect tumor, we will go ahead to biopsy and then do CT scan. So as you can see, the imaging is performed only for suspecting tumor, underlying systemic causes, and granulomatous causes. Now, there's been controversy regarding biopsy. Our objective of doing a biopsy is to determine what's the cause behind the perforation. Biopsy does not come without a risk, as we are in fact inducing crusting and bleeding in a stable perforation, and it can lead to enlargement. And therefore, there's no reason to biopsy if we've got a clear trauma, or surgical history involved, and if the edges appear healthy. However, we would biopsy if we are suspecting malignant tumor to rule out infectious diseases and in granulomatous conditions, because in wetness granulomatosis, we don't want to do a surgery when the patient is in active disease. In fact, we must wait for the patient to be in remission and for the ulcerations to heal before we proceed for surgery. Also, we can take culture from the sites of the perforation to look for Staphylococcus colonization that helps in medical treatment. Now, when taking a biopsy, please note not to take biopsies from the superior margin, as this will affect the vertical diameter of the defect and increase difficulty in further closure. This is a flowchart of how we can approach nasal septal perforations. If the patient is asymptomatic, no treatment is required. But if the patient is symptomatic, we want to see, is the patient a surgical candidate or not? If the patient is not a surgical candidate, we will go for the conservative approach, which includes using intranasal humidification, use of antibiotic ointments, epistaxis treatment, trying to treat the cause behind the perforation, and using a nasal septal button. If the patient is a surgical candidate, this will depend on whether there is a small, medium, or large perforation, and we can proceed to nasal septal buttons, the closed endoscopic approach, or the open approach. So who are poor surgical candidates, and what are the contraindications to correcting a nasal septal perforation? This depends on the state of mucosa. If there is poor wound healing in diabetics, or a patient who is a smoker with mucosal atrophy, one might need not to address the perf. If there's continued misuse of topical nasal medications, or it's a cocaine abuser who is not going to stop using cocaine, we don't want to proceed with operation. In fact, one can even offer psychiatric evaluation for such patients. If the medical comorbidities which preclude the need of the general anesthesia, we won't operate. Acute infections such as invasive fungal sinusitis or acute rhinosinusitis, uncontrolled inflammatory diseases, sinonasal malignancies are also some of the contraindications to surgery. So as I mentioned earlier, the medical treatment includes saline nasal irrigation, and this is of alkaline medium. The aim is to prevent crusting. Antibiotic ointments, such as mupirocin ointment for 4 to 6 weeks and reassessment thereafter, and topical nasal estrogenic spray and petroleum-based ointments can also be applied. Now, we use a nasal septum button in order to close perforations which are 1 to 2 centimeters in size. This is advantageous in the sense that it can be placed in OPD. However, patients do experience nasal obstruction due to accumulation of debris and local inflammatory reaction, and often require seek removal, and nasal hygiene needs to be explained to such patients. Coming to surgical endoscopic repair, again, this is tailor-made regarding the size of the perforation and whether or not there is a residual septal cartilage. So there are various surgical methods that exist, but I will be explaining on some of the grafts and flap methods that can be used. Before going on to the grafts and flaps, I'd just like to point out in consent for a patient going for operation, one must explain the patient that permanent complete closure may not be possible. We could use an auricular cartilage or a rib graft as interposition graft in the operation, and any existing pathological changes such as saddling or columnar retraction or deviation may be attempted. There could be injury to the nasopalatine nerve, which will lead to sensory disturbances in the nasal floor, and there could be injury to the nasolacrimal ducts, especially in inferior transposition flaps. The various grafts that we can use, the autologous grafts, which include septal cartilage, temporalis muscle, ribs. We've got allogenic grafts. We've got xenogenic grafts, such as intestine of horse pigs. And we've got also alloplastic materials, such as titanium and bioactive glass that has been used to close septal perforations. But I'd just like to point out that rib grafts are better than auricular grafts, as rib grafts tend to provide length, stiffness, and proper contouring for repair of the septal perforation. There are various flaps that can be used, local flaps, which include from the turbinates. It can be a bipedicled or unipedicled graft. We've got vestibular flaps, turbinate flaps, free grafts, which include fascia lata, fascia temporalis, and we've got perpendiculated grafts from the frontal and temporal region. Most common flaps used are inferior turbinate pedicle flap, and the advantage of this flap is that it can be used to reach a defect that involves the columella. The only complication of this technique is there's bulk associated, and adhesions between the septum and remaining inferior turbinate can occur. And there's also a possibility of flap necrosis and synechia formation. The preferred technique is sublabial mucosal flap. In this flap, it is a medially based pedicle flap taken from the oral cavity and tunneled through into the nose. And the disadvantage of this is that there can be a persistent oronasal fistula and the flap can necrose. It's been noted that some can use facial artery musculomucosal flaps, but the limitation of this is that some patients can have cheek tightness at the donor side. This flap is based on the facial artery. A radial forearm free flap can be used for large defects. However, it is associated with donor site morbidity and can lead to dryness, nasal dryness, secondary to the dermal lining within the nose. For perforations up to 2 centimeters, one proceeds to do an open rhinoplasty approach, and this flap is based on sphenopalatine artery. The advantage is that there's full flap elevation from dorsal perspective and a high success rate. There is also a surgery which is called the septal perforation enlargement surgery. This is attempted for very large perforations subjected to crusting and bleeding. And the principle behind is to bite off the posterior margin further back and to raise and preserve the mucosal layers on either side of the perforation, making sure it is long enough to wrap around the posterior margin. It is of note to note that there is no possibility of returning to repair the perforation if this has occurred. Coming to pediatric septal perforations, one has noted that button batteries tend to account for most common trauma to the pediatric population. And button batteries have alkaline fluid, which leads to cartilage necrosis and subsequent destruction of nasal structures, impaired nasociliary clearance, and deformity. Of note, it takes 4 weeks for the septal perforation to declare itself fully. Hence, when removing a button battery, one must follow up the child for the next 4 weeks in order to make sure that there is no septal perforation. It is tricky and challenging for rhinologists to address nasal septal perforations in children. The reason being, there might not be enough length of flaps available. And if ever flaps are used, it can affect the long-term growth of the nose. Hence, it is this algorithm helps us in knowing how to proceed. If a patient's got an irreversible etiology, we can proceed to using septal buttons and conservative management. But if there is a reversible etiology, we must see, does the patient have sufficient graft tissue? And thereafter proceed for either tissue transfer or free graft. Before I end, certain rules, tips, Tips and tricks while dealing with intraoperative problems. One must always suture the mucosa without tension, and this can be achieved by using a mattress suture. One can elevate large flaps without tension, even for small perforation, as this helps in success rate. The sutures do not hold the mucosa, and therefore it's important to include the mucosa with perichondrium and periosteum. If the mucosa is thin in areas of the perforation, we can use a long, thin needle and use hydrodissection to lift off the flap. And certain surgical principles that we must keep in mind is to make sure that if a perf is near the nasal valve, we do not completely occlude the nasal valve. We must ensure that there's adequate septum superior to the perforation in order to avoid the sagging nose. We can use an absorbable vitral suture on a round body needle to avoid tearing. We can use horizontal mucosal incisions to avoid damage to artery. And it's always advisable to use a middle layer interpositional graft for scaffolding. Lastly, some post-operative complications and how to avoid them. Hemorrhage can occur, and this can be controlled intraoperatively by cauterization, warm water irrigation, and nasal packing. Septal hematoma abscess and oronasal fistula can be addressed by eliminating the dead space with mattress suture. Intranasal synechia can be lysed. Diosmia can be avoided by avoiding septal mucosal injury, especially in the superior and middle turbinates. Epiphoria can be avoided by avoiding the lateral nasal wall superior to the Hassel's valve. Infection can be avoided by always covering patients post-operatively with splints with a first-generation cephalosporin. Nasal deformity can be avoided by use of nasal septal prosthesis. And in case of flap failure, worsening of perforation, or creation of a new perforation, attempt second repair after 6 months of healing and consider an open rhinoplasty approach compared to an endoscopic approach. These are my references. Thank you for your kind attention. Are there any questions?
Thank you very much. As an excellent summary, even for getting answered. Matt, what do you comment?
I haven't managed many septal preparations. We don't see them that commonly, to be honest, in our clinic, in my experience. I think one should always opt for a conservative approach because all the rhinologists have spoken to is in general the success rate of the surgery is not very high. I know when I last spoke to Professor Divya, she's a big fan of the sublabial.
Yeah, I think just before that, I've used a vaccinated tap or current tap you referred to, but it's quite bulky. And I had to go and divide it subsequently just to so we certainly, and I think the same will apply to the forearm tap, it's also bulky. The risk also to the forearm tap is using very small tap, you might have that perforated when it gets on the skin. So I think so those two taps that wouldn't be the top of my list, just from a bulk perspective. Any other comments from the audience? Anyone to comment?
Are there any comments from any of the people joining us this morning? I don't see any hands raised. Hazan, are you still on the call? I don't know if you have any comments. Nice to hear from you.
Hi, everyone. My connection is not so good, so that's the reason I don't know. Can you hear me?
I can hear you, Hazan.
Hi, everyone. Divya, that was a nice presentation. Thank you. But I think for the septal perforations, usually I don't operate on them if it is really not necessary. Because it's very risky. It doesn't work all the time. and people do well with conservative management most of the times. If all the complaints is persistent, then you can try to go for surgical approach. I'm doing mostly endoscopically. What I'm doing is mostly using the nasal flow rotation flap, which is a very easy, very nice flap that you can use. But if the perforation is too anterior, it's a little bit tricky. Then you can think about using that inferior turbinate flap that you mentioned in your presentation. But that one is a two-stage surgery usually, and it's not always so easy to cut the pedicle in office settings. It depends on the patient. For older patients, I usually use conservative management. Sometimes if it is a very small perforation for older patients, I'm trying to do that, making it larger. That's also I'm doing, and it works very well. If the perforations is very small, that's a big problem. But if it is a big perforation and posterior perforations, it's completely fine to do it. I think that's it. That's how I do it. Thank you.
Awesome, thank you, Azar. Nice to hear from you.
Yeah.
Are there any other comments?